Dear viewers, welcome you all to our show OSA, that is Orthopaedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is the peripheral vascular disease and the ultimate treatment by Ilizarov. Is it possible? Yeah, it is possible, but how? We are going to know about that. So stay with us. And our honorable speaker is, just like before, the very magnificent and one and only, the Professor Mofakharul Bari sir. I would like to request Professor Mofakharul Bari sir to join with us. So welcome to our show.
Thank you so much for introducing me, Tanveer.
You're most welcome, sir. Dear viewers, we have three academic panel with us. One of them is very learned Professor Novikov sir from Kurgan, Russia.
Good afternoon.
Sir. Good afternoon, sir. The another one is Professor Manish Dhawan sir, the senior consultant from New Delhi and the past president of ASAMI. Professor Manish Dhawan sir.
Yeah. Thank you very much for such a nice and kind introduction. And I really appreciate that I am at your platform. Thank you.
Thank you very much, sir. It's a great honor for us. And the third one is Dr. Shamsul Huda, and he is the Joint Secretary of ASAMI India. Dr. Shamsul Huda, sir. Would you please join with us?
Yeah, Dr. Tanveer, good afternoon.
Good afternoon. Dear viewers, we all know that the peripheral vascular disease is a very challenging disease. And how it is treated by Ilizarov. Is it possible or not possible? And we came to know the innovative treatment of Ilizarov in case of peripheral vascular disease after this presentation. So I'd like to request Professor Mofakharul Bari sir to start his magnificent presentation. And I am Dr. Mohammad Tanveer Ashraf as a moderator moderating this program. So Professor Mofakharul Bari sir, would you please share your screen with us?
Thank you so much. My dear all friends, especially Professor Noviko, Professor Dhawan, Manish, my very good friend, and my younger brother, I can say, Dr. Shamsuluddha, he's all the time with us, and Tanveer also, and the viewers, and those who are listening our topic. And today I would like to talk on the very important and very serious disease that is called the thromboangiitis obliterans, or you can say Barger's disease, and peripheral vascular disease. And particularly, I will talk on this one. And our sequential next topics will be on, I'll talk on diabetic foot, I'll talk on ischemic limb. And so these are the institutions where I worked. This is also our institutions. At present, I am working the two diabetic hospitals, very big in Dhaka. And we are getting lots of diabetic patients with diabetic foot that I will show you later on. This is my center, Kurgan, and everything. See, Barger's disease or thromboangiitis obliterans is an episodic segmental inflammatory thrombotic disease that most commonly affects the arteries and superficial veins, resulting signs and symptoms of ischemia of both upper and lower limbs, usually in men between 25 to 45 years of age. The etiology of thromboangiitis obliterans is unknown, seen very commonly in smokers. Research conducted under the direction of Gabriel Abramovich Ilizarov led to the discovery of a number of biological responses that allow for controlled tissue growth. Destruction, when applied to a living tissue, was shown to create destruction tension, which initiates and then maintains the regeneration and growth of the tissue structures. You all know all these things, and destruction controlled tissue genesis, and it became the foundation of a new technique developed by Ilizarov and his disciple, Professor V.I. Shevtsov, to treat patients with fractures and orthopedic diseases. Professor Ilizarov and Professor Shevtsov realized the applications of destruction to a number of other disciplines like plastic surgery and induced surgery. Look at these here. I would like to show you these two pictures. Remodeling of the leg shape. If somebody wants to increase the leg shape, then he or she can do this. See here, tibia, and see, you just make a osteotome, and just pulled, and this is your leg shape. And increase of leg shape, Wakari, you can do in this way. Do the osteotomy, and with the olive wires, you can pull. In 1982, Gabriel Abramovich Ilizarov proposed a clinical experiment to utilize distraction regenerative formation resulting from the transverse transport of a bone splinter to increase the blood circulation of the distal limbs in patients suffering from obliterative thromboangiitis. Kurgan studies provided evidence for increase in intraosseous pressure in limb ischemia and osteomyelitis after Ilizarov surgery. Now let us see what are the indications and the contraindications. Distal limb ischemia caused by obliterating arterial disease such as thromboangiitis obliterans, atherosclerosis obliterans, Raynaud's disease, and Raynaud's syndrome is an indication for microcirculatory situations. And if you think about the relative contraindications that include the compromised circulation in the lower leg, marked trophic changes in the region of the intended surgery, and severe concomitant diseases including psychosis. The method that I showed you earlier, like this, improving blood circulation by forming a tibial splinter, you can do that. See, these two rings, one ring here, only by 3 olive wires. You do the osteotomy here and gradually pulled out. What as a result, circulation boosting by the formation of a tibial splinter and its consequent measured transport. Here, if you look at this vasogram of the patient, that means leg thickening used to stimulate the circulation. Angiogram of the patient showing before and 6 months after the surgery. You see what happened here. Microcirculation. It's a very good circulation after doing this kind of surgery. Now, there are lots of variations and varieties. Stimulation of the peripheral circulation you can use by using wire implantation in the medullary cavity of a long bone. You put like this and do like this. It stimulates circulation. Next is stimulation of the blood supply and microcirculation by creating tunnels in the bone metaphysis. This particularly Professor Shipso did. I have done a lot of cases with him. Here you can see here, if you go for these 3-4 centimeter from the tibial tuberosity, and just you do a tunnel here, and in the lower part also you can do a tunnel here, and these two, you can see before surgery and after surgery, a lot of changes. Technique of a tunnel drilling through the metaphyseal part of the bone. Thermograms of a patient diagnosed with atherosclerosis obliterans before and after surgery. Now, boosting of the circulation through scooping out osteotomy. This is scooping out osteotomy. Sorry. Okay. Scooping out osteotomy here, boosting of the circulation. 2 things in the upper part, that is here you can do scooping out osteotomy, radionucleic angiogram. You can see here you can do scooping in 2 places, here proximal and distal. And then the standard treatment modalities, discontinuing using tobacco. I told you earlier, smokers are the first candidate. Foot care, calcium channel blockers, prostaglandin analogs, revascularization, lumbar sympatherectomy, and finally amputation if all above fails. In 1980, Barger published clinical and pathological observations of severe ischemia of the extremities, alternate name thromboangiitis obliterans, or we can say peripheral vascular disease. Clinical manifestations: heavy smoker who began smoking at an early age, are pain, often excruciating. Look at this picture, how it is going to happen. Platelet mass embolism, including bacteria, comes and migrating phlebitis with bacteria or DVT. Associated symptoms: migratory superficial phlebitis, cold sensitivity, and food claudications. Now, what are the signs? How you can identify signs and symptoms? Tingling or numbness in the hands or feet, pale, reddish or blue tinted hands or feet, pain that may come and go in your legs and feet or in your arms and hands. This pain may occur when you use your hands or feet and eases when you stop that activity, that is called claudication. Inflammation along a vein just below the skin surface due to blood clot in the vein. Fingers and toes that turn pale when exposed to cold, that is called Raynaud's phenomenon. Painful open sores on your fingers and toes. Pathology, acute stage, thrombosis in arteries and veins, digital vessels commonly involved. This is very important. And then you can see dense aggregation polymorphic leukocytes within thrombus, panvasculitis, but no necrosis of the arterial wall. And here is the three phases: acute, subacute, and chronic phase. What are the changes are occurring here? You can see here platelets, neutrophils, vascular fibrosis, erythrocyte, and multinucleated giant cells. Etiology, this is again I'm repeating, smoking is the sole etiology factor. Hormonal influence in the sex distribution. Genetic factor, blacks are rarely affected. Look at this. Thromboangiitis obliterans. And incidence 7 to 8 per 1 lakh in USA. Observation hour more frequent in Asia. Now let us talk about the management. Pain very excruciating, peripheral or sympathetic nerve blocks, temporary pain relief, lumbar sympathectomy. I have seen in my life there are lots of general surgeons, they are doing this, but often benefits. No specific medication has been proved to be useful, although anticoagulants, dextran, phenylbutazone, and steroids have been recommended. Now, you can see the arterial reconstruction is impossible because of the distal nature of the disease. And that causes the higher rate of failure. When gangrene occurs, amputation at the lower possible level is indicated. This is, now I would like to talk this gentleman, gifted scientist, innovator, destruction device for destruction angiogenesis in TAO. It's very important, the contribution of Ilizarov. 4 things we must keep in mind all the time when doing Ilizarov. Law of tension and stress, you know that very well. And corticotomy, also shown by Professor Ilizarov. Destruction, osteogenesis, histogenesis, neogenesis, myogenesis, dermatogenesis, everything. And lots of apparatus, myriads of ring fixators. I have done, I do go for duplex study for all the patients now. It is very easy, possible. You can see here lower limbs, arteriosclerotic changes in both anterior, posterior. Most of the patients are like that. And pre-surgery, this is before, you can think about the 15 years back. 15 years back, this case was done, obliteration of the popliteal artery, partial repermeabilization of the anterior tibial artery, and obstruction of the posterior tibial artery. And what we have done, widening of the limb. Destruction, as before all the time, 1 millimeter a day, 1 millimeter a day at once, 1 millimeter 4 times with 0.425 to 4 times a day, 1 millimeter a day by 60 times in automatic regime. And this is the procedure you can see here. Just I'm showing you this one. And I will go proceed. You can see how I do this case. Only one procedure. I should procedure how to do the surgery. You can see here the picture. Can you see?
Yes, sir. We can see you, sir.
See, just 5 or 6 minutes it will take. This is just first frame. Whenever you put the wire, just as soon as you put the wire, then and there I put the rubber stopper. You can see first ring. already I have introduced. First read these two words, and distance you can see starting from the below tibial tuberosity up to the 7 centimeter or 5 centimeter, 6 centimeter up to from the ankle mortise. Second, where we are giving second ring, introducing the wear, and then rubber stopper. Now, you can see I am putting the olive wires from medial to lateral side. Just a little bit below the olive, you make a small incision, and just you go for hammering. You don't need to cut the whole incision. You don't need to increase the incision. Little by little, you just cut, osteotomize, and then you go just like a rectangular. I'll show you the. I'll show you this after finishing this. Now see, already we have pushed how many? 1, 2, 3. This is 4 and 5. You put all olive wires. And this is the long bar with the hole so that you can go through this bar. Okay. See? Now what I'm doing, see, I'm just cutting just below the olive, from one olive to another olive, and you should make sure that you are in the same line. Same line. And after doing the osteotomy, we just tack it in C-arm, and surgeon can feel himself with his, osteotome with the hand. The bone is totally, you have separated. Even then, a little bit if connected, whenever you will pull, it will come down, just widen. See, still? Now you can see, okay. And particularly,
Dear viewers, we are facing some sort of network problems. Hope Professor Bari sir will connect within a very short time. I think Professor Bari sir will connect within a few seconds. Professor Novikov sir, are you doing these things in your institutions nowadays?
I am very sad because a few years ago, our administration closed angiological department. Ilizarov opened more than 30 years ago, and we have so many patients, and with excellent result. But our institute is Institute of Orthopedics and Traumatologists, and very difficult go through law. From ministry, we haven't permission for surgery like angiologist. But sometimes we have this patient with some problem with arterial or venous vascular system, and we do, but I can say like unofficial.
Okay, sir.
And I am
Sir-
happy because today I see this is technique with the excellent, perfect result in Asia. I can say congratulations because you follow of our teacher.
Yes, sir. Yes. Sir, did you done this before 2 or 3 years ago?
Yeah, yes.
Then what about the result of this sort of surgery?
I can say fantastic because from very bad situation near the amputation, patient back to the normal life. In orthopedic case, we haven't result like this. With angiologist result, with this type of surgery, we have fantastic results, incredible results.
Sir, do you add some medications along with this Ilizarov surgery for the peripheral vascular disease, or only the Ilizarov wires can help the peripheral vascular disease?
No, you're absolutely right. Patient need some medication, and all of this patient follow recommendation of angiologist for prevent of thrombosis, like that. I don't know medication in your country or in India, but usually we use or Pradaxa or Clexane, like that. Maybe you have in other medications, but all of these patients has some list of drugs with medicine and result more better. If we continued only with Ilizarov wires, Ilizarov system, result will, but not so strong like with medication.
That's great, sir. Sir, do you do any angiogram in this case to find out the amount of clot, or to find out the site of clot in case of peripheral vascular disease?
Yes, yeah, you're absolutely right. Before treatment, sometimes during the treatment, and after. This is our guarantee what you do, because this patient which show Professor Bari haven't any orthopedic problems, and Dr. Broken, maybe this is picture like angiogram we need for law, for court, if patient, for example, not satisfied, and we can show angiogram before treatment, nothing, and after treatment we can do a new angiogram with excellent red of new blood vessels, and all of patients through these examinations.
Thank you, sir. Thank you very much. I would like to request Professor Manijan, sir. Sir, would you please share your experience regarding the peripheral vascular disease and the correlation of Ilizarov?
Yeah, I have experience of 12 cases. I have done in 12 cases. I don't have a big series like Dr. Bari, but yes, 12 cases. But I tell you that it really works. You know, the most important thing is that once you do the procedure, the very next day or the same day, the pain disappears, pain reduces. And most of the patient, because before surgery, these people have a lot of pain in Buerger's disease. So once you do this osteotomy after surgery, pain is reduced markedly. So this is very important, and I have seen that in my all 12 cases I had success. But the pain reduces, and also the ulcers which are there in the, suppose there is a gangrene in the toes or some wound there down in the foot, it heals also. But in my country, it is very difficult to convince patient of a Buerger's disease to come for surgery and get the Ilizarov done. When they hear about Ilizarov, they get a shock. No, we will. And other problem with this is that all the vascular surgeons, they are not very convinced.
Yes.
Vascular surgeons are also not very convinced, but I have shown them the results. So they had given, most of the patients don't come to us directly. They go to the vascular surgery department. So,
yes.
But the results are excellent, marvelous. But only thing is that I studied these cases, but I could not, I had one question, which I have no answer for that. I agree that, this surgery, this osteotomy, increases the circulation in the limb. But how, I'm not able to understand how the inflammation reduces. Because Buerger's disease, there is a lot of inflammation. But what is the reason how the inflammation reduces? I think Professor Novikov can answer this question. I have no answer for that. I wanted to put this question to Dr. Bari also, but I think Professor Novikov just, if he can answer.
We have inflammation only after surgery, because our patient, maybe I can say hurt. We find gold medium, not all day in the bed, not walk too much, and support from antithrombotics treatment. We have, how I can say, normal inflammations, not so big. And this is field of angiologist. We start, if we have some arterial or venous problem, maybe must put leg with upper position in the bed for decrease swelling or inflammation. And if we have severe inflammation, we decrease speed of, how I can say, translation of fragments of bone. And for us, I first time heard you have a problem with inflammation. So big inflammation, we haven't. Any patient after surgery, including corticotomy for correction, has inflammation, but this is a problem for a few days, not for all period of treatment. And this is information for us, what we can do, or change position in the bed for patient, or give recommendation for medicine. And and all time we contact with angiologist, with real. We are not angiologist, and we ask specialities for some support. And on the finally, we haven't big inflammation.
Yeah, Professor Manijan, sir.
Overall, I say that results are excellent, because in all the 12 cases which I have done, I was also amazed to see the results. All ulcers healed, pain disappeared. So it works fantastically.
Sir, how long it takes to improve the circulation if there is a gangrenous toe there?
It takes around 2 to 3 weeks. 2 to 3 weeks. You have to do regular dressings. At least most of the cases I found that at 3 weeks, they show a lot of improvement in ulcers and the wound healing.
Okay, sir. 3 weeks after corticotomy.
Yeah.
Sir, what will be the corticotomy plan? Is it the same plan that we have done earlier, or it is in a different manner?
See, my technique is slightly different that I give. I go like Dr. Bari, I go around 2-finger breadth below the tibial tuberosity. But what I do that I make small 1 centimeter transverse incisions. I first do the corticotomy and then put the olive wires. Like Dr. Bari first put the olive wires and then he does the corticotomy. I do the corticotomy first, open it up and then put the olive wires.
Is there any specialty? Yes, sir.
No, it's not because I've learned this technique from my teacher in this way. I learned this technique from my teacher in this way that first make the window, first do the corticotomy, open it up, slightly open it up, and then put the olive wire. So the olive wire is stuck to that corticotomy, that thing, the open fragment, and then you apply the frame. Means it's the same thing, but I have been taught in another way. Like Dr. Bari first put the wires and does the corticotomy. I do first corticotomy and then put the olive wires. It's the same thing. Actually speaking, it's the same thing.
Professor Novikov sir, do you have any comment regarding this corticotomy and olive wire insertion?
And this is depend of surgeon, but I think technique of Bari little bit difficult because I am agree with Dr. Davan. First to do and finish, start and finish corticotomy, then very easy pass wire with oliva. But if Dr. Bari has this technique and has benefit, excellent result, why not? But I never do like Dr. Bari. Maybe when I will stay in Bangladesh, he will teach me of this technique. But I think this is a little bit difficult because must very properly to do osteotomy, very carefully. When we start, we from upper part, then go to down, very easy finish corticotomy, check with dislocation, and then very easy pass wire and fixation. No? This is depend of surgeon, I think.
I also make multiple drill holes. Like I know that my window is planned, so I will make drill holes, and I just follow the osteotome. And with drill hole, you are quite safe that you are not going to shatter it. You are very safe, once you make 1 centimeter.
Same.
You're absolutely right. Same. Yes, same. And once it is done, and then I open it up slightly and then put my olive wires.
Yeah, I am too. I am agree with you. For me, easy, but
easy, yeah, easy.
Dr. Bari is great surgeon. He can do like that.
No, I was
from another way.
I want to see his technique. Maybe some electricity problem there. I think electricity, Dr. Bari's place.
Yeah, I think so. He's out of his house, sir. He's in I think in a resort now, and he's attending a program from this resort. So he's facing that sort of problem. I think he will join with us. He's making the alternative way. Sir, I have one more question. That is the corticotomy is always, it is a transverse corticotomy or vertical corticotomy, sir?
No, it is like a window. Like you have to make a window. A window means it is basically one is vertical, long, then horizontal, and then you have to break the other cortex. You will not. You have to just break it with homens or levers. Means it is partial, and then you open it up with osteotome.
With osteotome. First cortex and second cortex.
Colleagues, this is our topic today. Excellent example with effect of Ilizarov. This is not apparatus. This is not method. This is effect. When grow, and we have excellent, perfect result with blood circulation. This is effect. Dr. Bari, we wait you.
Yes, there's something wrong with it. You have already heard my lecture or no?
No,
Yes, sir.
you were telling about your technique, surgical technique. We want to see that. You can start from your surgical video.
Again, you want to show, see the surgical technique?
Yeah, we
Yes,
actually
sir.
it was.
No, I
just,
think, Dr. Bari, after surgery. Just now we talk about
So
your surgery.
after
and
surgery?
yeah, we
Oh,
can.
after-
You can show after surgery.
External view or internal view?
No, sir.
I have shown.
So please start just after the video of surgery.
After
Just
the video
first of
surgery.
yeah.
Yes, I am proceeding further, quick.
I think the video is making some problem, so that it is stuck. It happens earlier also. Sir, you were telling about that the first cortex and second cortex we will cut it out by osteotome, and we'll make it to the third and fourth cortex by a Homans.
No. What we do, it's kind of a, you can say the corticotomy is like this. So we make multiple drill holes. We break this thing side and then just put your osteotome and just slightly open it up.
Okay, sir. Yes.
I don't have a diagram. So you are very sure that your corticotomy is full and you have opened it up, and then you can close it and put the olive oil.
See,
Yes, sir.
this is the, can you see this one?
No, sir. No, sir. We can't see the slide, sir.
You don't see the slide. I have shown you the
No, sir.
full video. Full video you have seen? No.
No, sir. It was stuck
Why?
during the operative procedure of that video.
Oh, and then case presentation you have not seen?
No, sir. No case presentation.
No case.
No case.
Come again. No case. I have shown you the
No, sir.
beautiful cases.
Sir, you
Now,
were
now,
disconnected.
can you see this one?
You were, no, sir. You were disconnected, sir.
Now you can see? Now you are
No.
you can see my screen?
No, sir. We can't see your
Hello?
screen yet, sir. No, sir. Yes. It's coming, sir.
Come in, wait.
Yeah.
You
The
tell
case
me. You tell
presentations.
me what? You see?
Case presentation. Yeah, we can see the slide case presentation. The headline case presentation.
This is you
there.
see. You have not seen this one?
No, sir. No.
Hello.
You were
We
disconnected.
finished
You were
now.
disconnected
Now-
with us, sir. Sir, please.
Can you see
were
this one?
disconnected. Sir,
No,
you
no,
were
no.
Now
totally
disconnected.
disconnected. You were totally disconnected, but now you are connected with us. We can see the case presentation, like case 1, that is Berger disease.
So how,
the
I could
thromboangiitis.
understand that you didn't tell me anything that I am disconnected from that one?
It shows that okay, no problem, sir. We can continue from now, sir.
Okay, just see.
Skip.
This
Yes, sir.
is you can see this one.
Yes, sir. We can see it clearly, sir.
See, this is an ulcer over the left grade 2. I described everything. Then I have done here, you can see here 4 olives. See this one. Stimulation of blood circulation, ischemic leg. Left side, stimulation of blood circulation, the ischemic leg and foot. Here this, then I'm going to process that. This is dynamic thermometry in ischemic leg and foot. See here, vasogram of the tibia. Distraction 7 days, fixation 5 days, total elongation 15 days, and distraction rate 1 millimeter per day. Second one you can see here, vasogram of tibia, Distraction 15 days, fixation 16 days, and total alignment 21 days. This is C. This is the before surgery angiogram. This is not moving. Wait. This is second after surgery. Beautifully it is shown. You know, you could not, now you cannot see. So next I proceed.
Yes, sir.
Next I proceed. See case 2. You have not seen this one also?
No, sir. Not.
No. But
not
now, now you can see?
Yes, sir. We can see it clearly, sir.
Clearly. See, look at the ulcer over the great toe. Bilateral lumbar sympathectomy was done. With this patient, came to my place, widening of the bone of the tibia. See, here lots of microcirculation, and after treatment, this is thromboangiitis obliterans. He was a smoker also. Now, see, this is publication in my Medcare journal, 2015, at that time 18 cases, now 24. Look at the face, just lip of this patient. Chain smoker, 50 sticks per day with ulcer. Then during treatment, with 3 olives I have done here. 3, 4, 5, 6, depending upon your case. Then see widening of the bone. Smiling with the patient. And now results 24, 23, I have 2003 to 2020, 24 cases. Relief pain, 22 cases. 2 patients with detemporation due to improper selection. And almost all the patients benefited. And I must say, this is the very good technique. If you do it, you can save a lot of things, lot of limbs. And these are my good friends from Kurgan. I showed everything. And unfortunately, I could not see that you have seen that one. Okay. We observed the, the Professor Shepsov, 80 years, when he came to Dhaka with other fellows. You can see here Novikov, Klushin, Borjunov, and Shepsov. And but I always admire this gentleman, a great scientist, talented doctor, gifted innovator, creator of the apparatus, the method of transosseous osteosynthesis. You can see this now. Now, see, dear friends, why complications arises after doing surgery with Ilizarov. Number 1, inadequate knowledge. Knowing anything, doing starts putting the words. Improper technique, violation of the original Russian Ilizarov principles, lack of skill, intelligent meticulous follow-up, lack of patience. This is very important. If you do the surgery, you must see the patient every day, your patient every day, regarding the distraction, compression, and hybridization. And these are the things, common things, and especially learning orthopedics is a hard work, requiring long days and nights to study, and learning the art of Ilizarov requires specific commitment for a lifetime. And I always say what I showed you, this is the evidence, science, and surgical skill. And we are happy that we are doing in our country with these cases. And we are getting a lot of cases with a diabetic patient, peripheral vascular disease, thromboangiitis, atherosclerosis. You don't need to go for diabetic ulcer for amputation. If you know this technique, you can save, you can salvage the limb. Thank you so much, dear friends. This is my Kurgan and Bangladeshi child with the Ilizarov apparatus.
Yeah, thank you, sir. Thank you for your excellent presentation. I think you have lots of questions from our academic panel, sir. Professor Manish John, sir, want to ask you something, sir.
Yeah, Dr. Bari, when we lost your video, I was discussing with Professor Novikov. Actually, my technique is slightly different. I have done 12 cases, and all 12 cases, my series is not as big as you, but yes, 12 cases and very good results, almost excellent result in all of them. But in my technique, I do the corticotomy first by multiple drill holes. Make small vertical, small horizontal incision, 1 centimeter. Do the drill holes, and then do the corticotomy, and then I put the olive wire. But in your technique, it is olive wire first and then the corticotomy.
Yes. Then I can, because I can easily put. You can do that also. You can do that also.
If you put the olive wire, how do you put it under and open your window? This is my question.
No, I just go below the olive, osteotope. Our olive is connected with the cortex.
Okay.
Below the osteotope, below the olive, this is your olive. I just make a small incision. Then I go below the olive. Then second olive here, small incision. I go osteotomize like this small osteotope. Then I do osteotomy here. Same case, everything. And rectangular from this side, this side. The way that people are doing like that also. Whatever you feel comfort, you can do that. No problem.
Second question I put it to Professor Novikov, that which I don't have answer, that once you do the corticotomy, patient has a relief in the pain immediately after surgery or next day. They are very, they have lot of relief. Now I don't understand this thing, that how the inflammation reduces. Circulation increases, but how inflammation reduces?
How inflammation reduces? This is technique. Increase of circulation, blood circulation in the whole limb. 330%. Ilizarov showed, not that 100%. Circulation and edema as soon as. You believe it not, believe it me or not, day before yesterday, I did one case. That was a diabetic patient with swelling of the whole ankle. And after angiogram, peripheral angiogram showed 65, 70, 85% anterior tibial artery, posterior tibial artery, even then involvement of the some popliteal region. And then I did the osteotomy like that. Second day, patient is telling me, sir, I'm getting for the last 8 months lot of medicines, but edema doesn't subside. And here, Professor Ilizarov and Shevtsov, they showed, the Kurgan people, Novikov also they showed, they know the intraosseous pressure of the bone, it increases. Pressure in that patient, peripheral vascular disease or diabetic patient or diabetic ulcer patient, pressure decreases. Whenever you do, you are creating the intraosseous pressure. That is the scientifically they have proved. They have an instrument especially, and they know how to do that.
And Professor Bari, one more question, that when do you remove the frame?
I do the distraction depending upon the case. You say some cases is a small ulcer, or I see the 10 days minimum, or 15 days, or 21 days. I go for distraction. That distraction I know, distraction, osteogenesis, histogenesis, angiogenesis, everything. Then I keep the patient for 3 to 4 months. Then I remove.
Okay.
And
any medication you give during the process?
Some very important, those were the smokers. Medication, of course, oxyphil CR, or Trentral. 200 or 400, I prescribe them. At the same time, I advise the patient, those who are chain smoker, nicotine is a ganglionic poison. It keeps in your body for 10 years. Today, you have stopped smoking, and for 10 years in your body, this nicotine will be there. Whenever you see somebody, those who are a smoker, they always doing like this. Do that. This is that. Those who are, those who drinks lot of things, their habit like this, always they are just moving their lips and tongue. So that's why I always advise my patient, please, very important, when he starts again smoking, one was the recurrence rate, he has started again smoking. I told the important thing is this, and Trental or Oxyvel.
Okay, that's great, sir. That's great. Thank you very much, sir, for sharing your knowledge with us. Professor Novikov, sir, do you want to ask something to Professor Bari, sir? You are telling something about that.
Dr. Bari, what do you think? This is surgery we can recommend for angiologist, not for orthopedic traumatologist. I like methods of treatment for angiologist surgeon. Because you observe.
Yes. Listen, Professor Novikov, you just listen to me. We have a vascular surgeon here, very good. One vascular surgeon, he is now retired, Professor Nurul Aga. He's trained up from Russia, and he knows these things. But how to apply the Ilizarov, he doesn't know. And he always referred to the cases to me, because digital vessels, you cannot repair. The main cause of the impairment of the digital vessels in case of atherosclerosis or thromboangiitis obliterans. And he referred to the case to me because he trained up in Russia. He knows the Ilizarov can help by creating a new vessels. That's why I tell all my general surgeons, you come and see, please. While I'm working in diabetic hospital now, I'm showing them, and they are seeing. All the time they are cutting toes, this and this. I will say, you can see. And I have shown them the literature. This is worldwide known. In India, a lot of publications. In America, they are not doing in America. I asked Dhruv Pale, have you done? Even J.S. Kulkarni asked Dhruv Pale, have you done? Anyone? No. But in Asian people, we are doing, we have a science, evidence.
Dr. Bari, only for this one surgery, our teacher, Professor Ilizarov, we need ask our society and give him Nobel Prize only for this surgery. Not for Farad, not for me, only for this surgery. And put gold memorial, gold monument for one surgery. This is incredible, fantastic treatment, methods of treatment.
Yes.
Yeah, definitely, sir. This is an unbelievable surgeon and unbelievable surgery, as because of we can't imagine if we can't see the evidence. And when we see the evidence, it becomes a science. As Professor Bari sir mentioned in his carry home message, that is the evidence-based science. Thank you, Professor Mofakhorul Bari sir, for your excellent presentation. And thank you, Professor Novikov sir, Professor Manish Dhawan sir, and Dr. Shamsul Huda for being with us. And yes, Professor Bari sir, do you want to add something?
Only 30 seconds.
Please,
I must congratulate these three gentlemen. Manish Dhawan, very long we are friends. Of course, Novikov all the time. My young brother, Shamsul Huda. I must congratulate. Thank you. We are carrying on. This is 19th or 20th. This is episode. How 19th. Many?
Yeah.
19th episode is going on. And thank you so much. Manish Dhawan joined in 2. Shamsul Huda almost all. Professor Harshad. Yes. Then we are planning to invite because we want to share our knowledge and we want to take something from you also. Not that I know everything. No. I want to learn from you. I want to learn from my mistakes so that I can help our patient. And that is our, all the time I show this one, the science, evidence, and surgery. Without that, I cannot talk. And I have the publication. Thank you so much.
Thank you, sir.
Thank you very much.
Thank you very much, sir. Yes, sir. It's a great honor for us also that we have Professor Mofakhorul Bari sir with us. And thank you very much, all the academic panel. for being with us. So hope we'll see you in our next program with another topic that is definitely related to peripheral vascular disease, and it may be the diabetic food. Until then, I'm Dr.
Okay.
Yeah, it may be the diabetic food or the ischemic limb disease. Until then, I'm Dr.
By wire technique, only wire, playing with the wires.
Yes, that means the ultimate treatment by Ilizarov, the magical Ilizarov.
Thank you.
And dear viewers, I hope you will be with us during that time. And I'm Dr. Tanvir Ashraf telling bye-bye to you, and hope you will spend a very good time for the rest of the period of your life. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.